Right. So as far as financial disclosures, I have none. But I did want to mention that in this presentation, I will often use the term woman and really do wish to acknowledge that many people experience midlife symptoms with a wide range of gender identities, hormones, and anatomy. And the research findings and treatment options that we'll discuss today are really relevant to most people with midlife symptoms. So I'd like to begin with a case. This is a 52-year-old CEO. This was a case specifically designed for the Boston Club. Of a small biotech startup who presents with frequent hot flashes, night sweats, sleep disruption, fatigue, vaginal dryness, painful sex. She's menopausal. She had her last period 1 year ago. She has tried everything: black cohosh, soy, yoga, meditation, acupuncture, lifestyle changes, minimal symptom improvement. She's considering hormone therapy, but concerned about the risks, including cardiovascular disease and breast cancer. Fatigue from disrupted sleep is adding to that challenge of keeping up with work demands and family responsibilities. She's concerned about experiencing a visible and distracting hot flash during an upcoming presentation to potential investors. So I hope that case rings true for a lot of you. So when women come to see me at midlife, they're coming with symptoms. But I do always want to stop and say, this is an incredibly exciting time. This is the beginning of the next third of your life. We're so lucky in the developed world that most women at 50 will probably get to see 80. And so it's important that those years are healthy and productive and pleasurable. So I do want to focus a little bit. I won't be talking about it today, but make sure people are keeping their bones strong. They're attending to their cardiovascular risk, of course, the #1 cause of death for women, whether that's exercise, healthy weight, good diet, treating that hypertension and high cholesterol. And of course, this is a really good time to step back and make sure cancer screening is up to date, colon cancer, mammography. So a good time to just look at health. On the other hand, women are really coming to us with symptoms. Principal symptoms are typically hot flashes and night sweats. We call those vasomotor symptoms, and vaginal dryness associated with painful sex, but important to realize it affects women in their daily lives as well. Other symptoms women will talk about: disrupted sleep, painful sex, depression, weight gain, fatigue, low libido, brain fog, anxiety, and insomnia. Sound a little familiar to those of you at this time of life. I am a bit of a domino hypothesis believer, because I think that if we can really treat those hot flashes with all of that sleep disruption, for most women, a lot of those other symptoms just fall into place. For anyone who remembers what it was like to be up all night with small children and you just don't think well, you're irritable, and sometimes just really helping women treat those symptoms, get a good night's sleep, a lot of the other things fall into place. Well, how prevalent are hot flashes? As you can see here, they really do affect up to 75% of women. At least 50% have the really bothersome ones. Although they peak at the year of the last menstrual period, important to realize they can still happen when women are still cycling. So yes, if you went to your clinician in your early 40s and you were still pretty much having regular periods but having some night sweats and sleep disruption, that was perimenopause. And I think for most women, these perimenopausal years are actually even more challenging than after that last period, when you really know where you are. They last many years. It is important to realize there are a lot of ethnic and racial differences. Some beautiful studies out of SWAN, a really important national study that's looked at ethnic and racial differences in the menopause transition, has shown us that Black women are likely to have more severe, more bothersome hot flashes, and they're going to last longer. So it is important to consider all of that when estimating whether you should treat them or not. They can be bothersome and last a long time. What are some interventions? Clearly, most women have figured out staying cool helps. And actually, here's a really nice study. Women in a cold room and in a hot room, and you can see a really big difference in hot flashes. So all of the things you're doing with desk fans and AC, evidence-based. Some of the things that women try, and I encourage them to try if they want to: acupuncture, some of the soy products. They work. They will reduce your hot flashes about 30%. But when we do careful studies with placebo acupuncture or with a placebo soy product, probably no better than placebo. Doesn't mean you may not want to use them, but probably no better than mind over matter. Well, what is the most effective treatment we currently have for hot flashes? It is hormone therapy, also called menopausal hormone therapy. What you can see here is women without a uterus just need to take estrogen alone. Here's the placebo group. Placebos work. This is reduction in hot flashes, but dramatic improvements with estrogen. Women with a uterus, again, dramatic improvements with estrogen and progestogen. Well, what about risks and benefits? Back kind of in the 80s and 90s, there were a lot of observational studies that not only did hormone therapy treat hot flashes, vaginal dryness, and preserve bone density, which we knew, but there were a lot of studies that said it might also reduce the risk of heart disease. And of course, that's the number one cause of death for women. It would be wonderful if you could have all those other benefits and reduce heart disease risk. Very important to realize these are what are called observational studies. So we basically looked at women who chose to take hormone therapy and then looked at their risk of heart disease. And what we do know is that women in those years who chose to take hormones were actually healthier to begin with. They were at lower cardiovascular risk. They exercised more, healthier weights, lower blood pressure. And so a lot of what we saw as maybe a result of hormone therapy may have just been what we call confounding. But these data were very exciting, and they were exciting enough that the NIH undertook the largest study they ever did in women. And to be fair, they were also getting an awful lot of flack from a lot of people that women are not small men, and that the research in men should not just be dropped on women, say, maybe take a lower dose. So they responded to both of those concerns by paying for the largest study they've done in women, the Women's Health Initiative study, and probably most people have heard of that. Double-blind, randomized, controlled, very high-quality study looking at a placebo compared to hormone therapy. Women without a uterus got estrogen alone, women with a uterus got estrogen and progestogen, and then they were followed over time. And as you all know when you read the newspaper, what sells newspapers? Good news or bad news? Quick show of hands. Bad news. And not only do people learn their medicine from, well, we have really great presenters of information like Callie Crossley, but most of us look at the front page of the Globe. And so bad news sells newspapers. And so both clinicians and patients saw a lot of bad news when that study was released. And so what I'll show you here is, and those of you who you're business people, stock market, what really sells news, of course, is unanticipated bad news. So here it was, we thought hormones might reduce the risk of heart disease, and lo and behold, study is published, there is an increased risk of heart disease. The entire world panics, women stop their hormones. And when you really look at the data, this is a very small increased risk of heart disease. It's a 1.3-fold relative risk, or a few additional cases per thousands of women. But bad news, sold newspapers, and literally for the next 20 years, we have had a lot of anxiety about hormones, and a lot of women who really may have benefited not getting the treatment they need, and a lot of clinicians not getting the education that would be really helpful in who's a good candidate for hormone therapy. So just to show you, of course, breast cancer increased as well, but this is a 1.3-fold relative risk. It's actually the same as having an elevated body mass index, being overweight, or having more than one alcoholic beverage a day. So it's probably a real risk, but for a lot of women with really bothersome hot flashes, shared educated decision-making, those benefits may really outweigh risks. So I think one of the most important studies when we're looking at hormone therapy and risks, and I share it with my patients, and when I'm educating, this is the same exact Women's Health Initiative study, but they looked at the women under age 60. And to be honest, that's 99% of women who choose to take hormones for hot flashes. And what you can see is not only were there not increased risks, there was actually less heart disease, less mortality, and improved global index. Now, when women come to me with hot flashes, I don't say you should take hormones because they're going to reduce your risk of heart disease. There are so many other wonderful lifestyle changes and other healthy things you can do that instead of taking a medication. But I don't want you to worry that you're going to drop dead of a heart attack, because these data are actually very reassuring. And those data probably hit the 10th page of the health section of the Boston Globe on a Wednesday. So we tend to really hear bad news, and there's a lot of good news out there about potential benefits and risks of hormones. Put into perspective, if you look at 5,000 women years, 1,000 women over 5 years, there were 2 additional cases of heart attack, and maybe 2 of breast cancer. 5,000 women years, that may be a choice a woman really chooses to make if she's really bothered by vasomotor symptoms. And there were also some potential benefits. And this is women on estrogen alone, and you can see for women without a uterus, a lot of benefit. And of course, that study, when it was published, got almost no attention, the one on estrogen alone in women without a uterus, because it was mostly good news. So another piece of good news, if women choose to take their hormones by patch, a lot of women do that instead of pill, we don't even see a lot of those cardiovascular risks that we see in oral estrogen. And so you'll probably hear a lot of people talking about using a skin patch, and that does appear to be safer. So there are ways, not only I think is hormone therapy for women under 60 safer than a lot of people realize, even looking at the same data that made everybody stop their hormones, there are ways to make it even safer the way you choose to take it. So there are a few women who really are not candidates for hormone therapy, principally women with breast cancer or who have heart attacks, strokes, leg and lung clots. That's a very small percentage of women with hot flashes. The majority of women with bad hot flashes are pretty healthy and could really be a good candidate for hormones, especially short-term hormone use. Some of the risks really do go up with aging and with duration of use, and many women don't need the hormones for that long. Who else might not be a good candidate? Women at high risk for some of those other reasons. Someone who has a lot of cardiovascular risk factors may not be a good candidate. But there again, just a clinician who listens to you and some good shared decision making. So I think when this hit the press, and I think most of us in the field were kind of excited to see midlife women's health getting this much attention, it really did start the conversation. And I think the misled about menopause is that the very study for which women have not been kind of invited to think about hormones for 20 years actually had a lot of really reassuring data in it. It just wasn't shared. What are some alternatives for women who either can't or choose not to take hormones? SSRIs, SNRIs, some of the antidepressants are actually shown to be very effective in trials with a placebo in women without depression. And incredibly exciting, hot off the press, I think we finally have truly a non-hormonal treatment for hot flashes that will be as effective as estrogen. It has never been compared head-to-head, but what's incredibly exciting is that this is a designer drug. Some really smart researchers, after hundreds of years of not knowing where a hot flash started, discovered that something called candy neurons, these neurons in the hypothalamus, the same neurons that are responsible for puberty and for menstrual cycles, are probably the problem for hot flashes. These neurons fire very fast when you're menopausal because they're trying to get the ovary to make estrogen, but the postmenopausal ovary can't. So those fast-firing neurons probably have some nerve endings on the heat sensing parts of the hypothalamus. And so hot flashes are kind of a byproduct of these neurons on overdrive. And so some incredibly smart researchers designed a drug that specifically targets these neurons. It's called an NK3 receptor antagonist. It has just been FDA approved in May. And so really excited to think that for our patients with breast cancer, heart disease, and stroke, women who've maybe been on hormones a really long time and risks are increasing and they can't come off, we now will have a really effective alternative for them. So I think that will change the conversation. We're going to be talking mostly about women at work today. Should we be changing the workplace, or should we be making sure that women have effective treatment for their bothersome symptoms? So be a good discussion later. And this is just the slide showing you the drug that's approved is this blue line. This is placebo. It works for hot flashes, but really a dramatic and effective alternative to hormone therapy for hot flashes. So very exciting. I will be honest, right now it's so hard to get the drug for patients. I'm writing long letters. It's very expensive, but clearly that will change with time. There's several other similar drugs in the pipeline, and so hopefully there'll be more choice, more coverage, and less cost. One topic that I really did want to discuss, because it's kind of a real research and clinical area of mine, not quite as important in the workplace, but incredibly important for midlife women's health, is vaginal dryness and what we call the genitourinary syndrome of menopause. This is highly prevalent, probably affects almost 50% of postmenopausal women. A very small percentage are actively, effectively treated. And if you think we don't talk about hot flashes at the water cooler, no one is talking about vaginal dryness and painful sex. And it's really important to talk about because just like for hot flashes, we have a lot of really effective treatments. And until we talk about it, women won't realize this is a natural part of aging, but treatable, and get the treatment they need. Over-the-counter, non-hormonal lubricants and moisturizers. Lubricants are designed to decrease discomfort with decreased friction with penetrative sexual activity, whereas the moisturizers are, again, over-the-counter, designed to use to line the vagina, keep it healthy, use it a few times a week. Very effective are some very low doses of vaginal estrogen therapy. These are essentially microdoses of estrogen placed directly in the vagina 2 or 3 times a week, or a little ring placed every 3 months. Lots of options. Why aren't women using these? Well, one reason, first just to show you, when we look at blood levels, when women use these microdoses of estradiol in the vagina, this is the menopausal number. Do you see any difference here? absolutely no bump in serum estradiol levels when women use these very effective products. But when they open their package insert, they see the exact same, very frightening package insert they would see if they were taking very high doses, not, if they were taking doses of hormones adequate to treat hot flashes. This is basically the WHI data that we just shared. And so we actually went to the FDA as part of the Menopause Society saying, there are really effective and safe treatments there that women aren't using because of this big black box. And guess what the FDA said? It's estrogen. So another good topic for our discussion, I hope, is, how can we change that conversation with our government? When we do some observational studies, what we see is no increased risk of all of the things that are in the black box in women who use low-dose vaginal estrogens. They are not at high risk for heart disease or stroke or cancer when we look in observational studies. So for education, just wanted to kind of close with that. A lot of great resources out there. One of my favorite, I helped work on some of these when I was with the Menopause Society, or something called MenoNotes, free, completely available. Google MenoNote, and there are ones on all of the topics that we've talked about today. Literally in 2 pages, we'll cover treatments for hot flashes, vaginal dryness, depression, sleep problems. Really encourage you to pull those out. And then there are a lot of great websites. Menopause Society, ACOG, Mayo Clinic, Endocrine Society, Swan Study, fact sheets. Women's Health Initiative has some great information on their website. Something terrific, another NIH-funded project, MS Flash, has something wonderful called My Menoplan, and Up to Date has a lot of great free information for women. At the Menopause Society meeting this year, our keynote was on disinformation. I think, as you probably realized, menopause has become profitable. People are realizing a lot of midlife women have some money to spare, and we have to be careful. There's a lot of marketing directly to midlife women that, of products that may not be effective or safe. There's a lot of disinformation. So please look for .orgs, not .coms. Avoid anything that says anti-aging. And then do be careful about menopause disinformation and profiteering. It's out there. So the real focus of today is the impact of menopause on women at work. So I did want to kind of bring up some things that I think we'll be discussing with Callie. Menopause really is an age and gender equity issue. Midlife comes at it, as other people have said, at a time that women are really rising in career success and leadership roles. There's a big economic cost. Healthcare expenses, lost productivity, lost advancement for women in their careers. Of course, on the other hand, as we talk about this, is this going to be another reason to discriminate against middle-aged women in the workplace? We certainly don't want that to happen. I think if we focus on the terms of optimizing workforce, that's probably the best way to bring attention, get the care women need, and yet avoid the risk of discrimination. Really exciting that as I was preparing some slides, I got a wonderful Harvard email about the economist Claudia Goldin winning the Nobel Prize for Economics, and the first time a woman's won it alone. And guess what? The topic of her work, the evolution of the wage gap for women. So I thought, what timing? What about some studies? A wonderful investigator, colleague and friend, Stephanie Fobian at the Mayo, did a study, a survey of women between the ages of 45 to 60 who were receiving care at Mayo, did a menopause rating scale, so she had some idea of their bothersome symptoms, and then asked some questions about impact on work. They got about 5,000 responses. Now, to be fair, whenever you look at a study like this, that was only 16% of the women who got the survey. So is this really representative? I think it's pretty representative probably of symptomatic women who said, wow, I'm bothered. I really do want to get that questionnaire completed. But clearly women were experiencing a moderate menopause burden. Their scores were high on that rating scale. 13% of women reported at least one adverse work outcome due to their menopause symptoms, which is typically missing work. And 11% missed at least one day of work over the past year, a median of 3 days due to menopause symptoms. They did this economics calculation and came up with $1.8 billion in the US annually. And again, these are estimates. It's not a perfect study, but it definitely is a great study to open the conversation. What is the cost of untreated menopausal symptoms at work? And then I did want to point out, really interesting, in the UK, they've taken this on head on. Came out in July of 2022. It was the United Kingdom Parliament House of Commons Women and Equalities Committee report. I don't think we have that committee in Washington. Megan, maybe you can do something about that. So essentially, the goal of this is to examine societal stigma and adequate diagnosis and treatment and workplace discrimination faced by menopausal people. And it is important to use that word people. We do have a lot of menopausal people of different karyotypes. Investigate how government policy can provide better support in terms of both health, workplace, and law. For instance, they talked about better education required of general practitioners about menopause and hormones, reducing the cost of hormone therapy, having menopause specialist services available, having menopause work leave policies, and even went so far to say that menopause should be protected under the Equity Act. So I think the take-home message was that supporting those experienced menopause makes sense for individuals, the economy, and society. So with that, would love to introduce Ms. Crossley. So thanks so much. That is the end of what I have kind of formally prepared to set the stage. And again, it is an absolute pleasure to introduce Ms. Crossley. And I want to say, in addition to the introduction you had before, she is incredibly committed to health education for people, and also really has done a wonderful job about raising awareness of the incredibly adverse impact of social determinants of health and inequities in healthcare. So hopefully that'll be another topic we'll discuss.
All right.
Great.
Well, first, let me give a compliment to Dr. Jen, because that was one of the most thorough briefings that I have ever attended. I don't know about you all, but I've been in a lot of rooms with doctors, and you did it. I just want to note that we are 1 week away from World Menopause Day, something I knew nothing about until prepping for this conversation. It's every year on October 18th, and commensurate with what you have just talked to us about, the focus this year is on cardiovascular disease. They pick a focus each year. And of course, the point of the organization that's been around for a while is to really talk in depth about all of the kinds of things that are not being talked about for most women, particularly in this country. In fact, I'll just say, Jan, when I went online, pretty much every little blurb you could get about just detailed information about menopause, somebody had a British accent. It was pretty interesting. Maybe an Australian one, but not very many Americans is my point. So I wanted to make one statement to have you extrapolate on, just because it just stood out for me in all of the material that I've been paying attention to, and that is, even though there is a broad spectrum of symptoms, every woman is so individual in how she may get one, two, many, none. I mean, I really think we need to speak about that to kick off this conversation, because if you're talking about making some kind of plan in the workplace or getting people to think about it, you cannot do a one plan fits all, because it doesn't work.
You are 100% right. And as a clinician who does a lot of midlife women's healthcare, a lot of what I do during the consult is just listen. And there is no one size fits all. Women's symptoms really vary. And remember, it's not just the symptoms, but the impact of those symptoms on her life. And so that's also really important to try to draw out. So yeah, there would not be one, there's certainly not going to be one easy fix. I think, really focusing on improved education, the conversation, and just having resources available for women will lead to that, able to individualize a response to care.
So let's go back to that Mayo study that you mentioned. That was August, that came out. And just to be specific about the adverse effects that these women reported, some quit, some were fired, some were laid off. And they directly connect that to experiencing menopause symptoms in the office. This is pretty intense, and we're at that point. And so it's really difficult, given some of the symptoms that we know about, one of them being hot flashes, to hide that in the office. So the next step is that we have to have conversations at the management level in the office. And I am not certain, and perhaps you have an example of something that's working through the Menopause Society, about how those conversations begin with line managers as a starting point.
I think it's really not happening. Women, think about it. We were even talking about this when we got together earlier. Women don't even talk to women. Even sometimes with your own friends, you're not talking about hot flashes, the impact on your life, the impact on your mood or your relationships. So if you're not even talking to your friends, certainly you're not going to be talking to your managers, some of your work colleagues. So yeah, I think until it's really a conversation at work, there won't be much change. Most people just try to hide the symptoms and kind of march on.
Well, here's some more bad news. We need more. You're kind of a unicorn. Folks who go through medical training get 1 to 2 days of training on this subject. That was startling to me.
Oh, yeah.
So if you're looking for a specialist, someone who can help you through this and try to figure out in your particular situation how to manage it, and certainly how to manage it in a workspace.
I think that my message there is, instead of trying to have more menopause specialists trained, I think there are about 1,500 of us in the country, we just need to, this is, as someone said, this is half the population's women. If we're lucky enough, we're all going to make it. And if we're healthy enough, we're going to make it to midlife. So this should be something that the internist, the family practitioner, and the OBGYN can manage. This should not require a subspecialist. These are FDA-approved drugs. They really treat the symptoms. There are some risks, but every medication we take for high blood pressure has some risks. Why is this an area where you need to see a subspecialist? So I think we almost need to take it back, and we should be teaching our medical students and our residents and our nurse practitioners and our nurse practitioner students. And this should just be, you should be able to go to your internist for your annual visit or for a specialty visit with the symptoms, and have someone listen and give you some treatment options, give you some resources.
But Jan, what the statistics have shown are not only women are not talking about it, most of them are toughing it out, yes, as opposed to getting any treatment whatsoever, whether or not they're concerned about hormone treatment. They don't even get there. They just say, I'm just going to tough it out. I mean, you can't really function like that in an office setting for sure, and in your life the rest of the time.
Right.
So how do we move those? Mostly, I think the number was something like 73% of our women tough it out
Right.
into a space where they at least are getting some kind of relief from symptoms with treatments that we know now work.
It's a great, I knew you would ask these great, really hard to answer questions, Callie. Nothing easy. There just has to be more education. There has to be more public awareness. There has to be more conversation. And then more clinicians, who have the background to just help women through. I mean, I think it's especially frustrating because we have all these effective treatments. So, on the one hand, I think we do have to talk about what can be done in the workplace. On the other hand, there are some companies that are providing these menopause education sites as part of their healthcare benefit. And I think that's a great option. We're actually started offering one at the Mass General, and a group of other people who do menopause and some other problems were like, "What did you hear? What is this? It's farming." I said, "Of course, I'm thrilled they're farming out some of this education to this terrific educational group, because we don't have the resources to provide that. This is just for employees at Mass General. We can't even give them the resources they need." And so I think that would be an easy start, for employers to realize that you do need to have, as part of people's healthcare benefits, now we're so used to virtual care. So these are typically, it's a benefit. And in the same way that I know at Mass General, there's now a mental health benefit. They realized they had to farm it out because there aren't enough clinicians at the Mass General to handle all of the stress and need. So you go online and it's part of your benefit, and you can identify a therapist, and there's a lot more access. And I think that's something that would not be hard or even that costly for employers to start doing. Identifying some of these they're for profit, but the one at the Mass General was really carefully screened, and all the information is accurate. The recommendations are accurate. You can get a nurse practitioner on the phone. You can join a group of other women and talk about symptoms and treatments. So I don't think that would be that hard to incorporate into workplaces and probably cost effective, right? Because if you get women the treatment they need, they're going to be more effective at work.
Well, the business case, of course, is that you want to retain and not recruit. That's what you want to do, because that's what happens if women are quitting or being laid off because of these symptoms. On the other hand, I have to say, what you have just described is an evolved workplace. I don't know about you, but I've had very few of those. Okay, not where I'm working now. I'm on the salary continuation plan. But I'm saying that is usually what the struggle is. And also, we as women, I'm just going to speak for me, and I know some others out here, we internalize the stigma. So we're hiding it, or we're not talking about it, not because we're not understanding what's happening to our bodies, but also we're afraid of the stigma. Mm-hmm. So in one of the conversations I saw online, the coordinator of the conversation said, all right, I'm going to throw out the word menopause, and I want each of you to just give me a quick response of what that word means to you. What do you think the majority of the word was? The majority of the people said?
Old.
That's exactly right. So the first word was old, and then somewhere down below was hot. And as the leader of the conversation said, and I don't mean the good kind.
I love it. Well,
so that's
Callie, why do you think that I decided to call our center the Midlife Women's Health Center?
Yeah.
Because menopause has so much stigma. And to be fair, I do want people to start to think about this more as a midlife issue, right? It is the beginning of that really important next third. There are a lot of symptoms, but there's also, this is a normal part of aging, and, so it shouldn't be so stigmatized. It should be, in the same way that, to be honest, puberty stigmatized too. It's another incredible life change. Often the one thing we've talked a lot about is, when you're going through, you're about to get your first period, your sister's talking to you. If you're lucky, your mom, your friends, you're getting education at school, someone's leaving some book, on your bedside table. You get a lot of education, and girls talk about it, right? And then when you're pregnant, and that's another really big life change, reproductive change, you've got classes, you've got support groups, right? You've got your friends and family. Well, what happens when you get to your early 40s? Nothing. No one's leaving a pamphlet on your bedside table. And and I think what makes it harder is it's not as visible as pregnancy. It's also not as time set. It's not as if you're 12 to 14, we know what you're going through. There are a lot of women who come in their early 40s. No one's talking to them.
Late 30s for some.
Late 30s for some. So I think we've got to change that conversation in the same way that we're putting those booklets on the bedside table before that first period, or giving that childbirth education class. As a community, it doesn't just have to be healthcare providers. Women can really share information in other settings too, and we're not. I don't know why that's not happening.
Well, we now know that the hormone therapy does work, and that there are some also non-hormonal treatments that are effective as well. One treatment or therapy that I haven't heard as much about, but for sure impacts women in the workplace because of this particular symptom, not hot flashes, but the cognitive fogginess.
So, I'm somewhat black and white when I look at this. I think when you are not sleeping, and maybe that's because I did medical training, and for years you're kind of on the edge. If you're not sleeping well, there is no way you're going to remember where you drop those keys, right? And so I think for women, they come in and they're frightened. Is this going to be Alzheimer's? I can't remember where I left this and that. And once they're sleeping well, and for most of my patients, it's because they had bad hot flashes and cognitive changes, and we're getting them to sleep, it just gets better. So I think, it's pretty rare that someone comes in and says, I'm just foggy, I'm just not where I am, and I'm sleeping great. They go together. And so for some women who can't take hormones, we're focusing really on the sleep and other sleeping medications. And I'm really excited that, we hopefully will have a really good non-hormonal alternative, because the sleeping medications have side effects and risks too. But I think a lot of that cognitive stuff is sleep.
Some people are suggesting actually what we would call talk therapy or cognitive as a very good intervention. Would you?
There's some data to support that.
Okay.
Yeah.
So that we should get beyond just, maybe it might be more than sleep, because there are also some depression tendencies depending on where you are on the spectrum of symptoms and response. So what is it?
Callie, I have one other thought on the cognitive question. This is, I think, helpful. So I think the other thing we forget is that midlife is not just a time of symptoms.
Right.
It's a really hard time. So I don't know about any of you, but I just brought my 92-year-old mother into my home after a hip fracture, got this job. Luckily I have a pretty reasonable 30-year-old who's actually got a real job. But, COVID, he was living in my house. He's a pretty good cook. It wasn't too bad. But, your kids, if you have children, need you in certain ways. If you're partnered, they're going through a lot of midlife changes. Your parents, if you're fortunate enough to still have parents who are alive, they often really need you in ways. And then often you're at a point in your career where you don't have the same flexibility you might have had at other times, and you're taking on more work responsibilities. So just, even if you had no symptoms at all, this is a hard time. 40 to 60, it's a really hard time. And we're often multitasking. So this is just a personal story, but there's an incredible brain researcher named Pauline Mackey, who I work with at the Menopause Society. And we were at a meeting, and I pulled her aside. I said, okay, Pauline, I'm really worried. I'm in this big garage at Mass General, and I have come out for several days. I have no idea where my car is. And I think, I need to be tested for dementia. She's like, Jan, I have a question for you. When you walked out of your car, were you on the phone, looking at your pager, carrying your tea, and trying to grab your briefcase? I said, well, of course, that's what I do every time I get out of my car. She said, you didn't forget where your car was. You never learned where your car was. And I was like, and now it's a little geriatric, but I get out of my car and I say, upper B. And then I have not misplaced my car in 2 years. So, I think sometimes what we get really worried is early dementia is a lot of other things. It's attention, it's all the other things going on in our lives, and it's sleep. Sleep is incredibly important.
So I know we're going to your questions, and I just want to remind people that you can go #menopause to slido.com and get right on, or you can use the QR code. One of the things that you emphasized in your talk, and when we first talked, you were concerned about is this marketing to women. However, as I turn on the TV now, I'm seeing these ads for Veoza, and that's one of the first questions. Does it work?
That's the drug I just presented. It works. And what's so exciting is it works because I think we finally figured out where hot flashes come from. I mean, I've been in this field for, if I'm 60, 40 years. And I've always had to start my lectures to the medical school. We really don't know the true pathophysiology of the hot flash, which is incredible. I mean, this universal symptom. And we do. So I think it really does work. Yeah. Now, there's a lot of discussion about where will it fit in our armamentarium. How will it compare to hormone therapy? In the women under 60, a healthy woman in her early 50s, there are some other benefits to hormones besides just hot flashes. Will we be kind of starting with hormones for healthy women in their early 50s? And then if most women can come off after a few years before a lot of the risks incur, will we use it for women just with absolute contraindications? It's really kind of a lot of exciting conversation, in the Menopause Society where this drug will fit in. But yes, double-blind randomized placebo-controlled trials, it looks really effective and safe.
Okay. Really what we have in this room and of the people who are online are pioneers, because this is the first big cohort of people being outspoken or even speaking a little bit in public spaces about menopause. So this question, I think, is very interesting, and says, how do women leaders talk about menopause and support in the workplace? We're beginning those conversations. We're not there yet, we can all agree. What's your suggestion?
It's a great question. I kind of want to throw it out to our audience because we're filled with all these women leaders. How do you all talk about it in the workplace? My hunch is it's not being talked about. And, I think there's, there's something like the book club, right? It's this incredible way that women get together. Why can't women start to say, hey, let's have a midlife club? Let's get together a little bit, and we could do some reading. There's some great articles, there's some books related to this, but let's really focus on what's it going to be like from 40 to 60? How are we going to work through this? What are some symptoms you've experienced? What are some treatments you've done? How can we support each other in the business world? So,
can you explain how sex is painful during menopause? I think you hit it in there, but you can underscore it.
that really is an important both research and clinical area for me. I think if people aren't talking about hot flashes, no one's talking about this. And it is really sad that there are so many effective and safe treatments. And so if you think someone's hesitant to tell their clinician about a hot flash, unless clinicians ask, and I ask at every single visit, but most people don't. And so women have to bring it up, and they shouldn't. Clinicians should be asking, and people should be bringing it up. It's a really common symptom. And if you think women think that they should live with hot flashes, they just assume this is part of aging. And it will happen with aging if there aren't treatment interventions. So there again, I think just education and starting the conversation, and it would be less frustrating right now if there weren't effective treatments. But knowing how many women are suffering and that their effective treatments is really painful. I did some work in libido and some research when I was younger and testosterone, and then I kind of was realizing the majority of the number one reason why most midlife women have low libido is it's painful.
Yeah.
And why would anyone want something that wasn't pleasurable and comfortable? So it seemed like that's really the place we have to begin.
You asked the question during your presentation, there are all these treatments for this, and why aren't people using them? Answer, no one knows. There are all these treatments. I'll just answer that question right now.
I think that's a lot of it.
Okay. This is an interesting question. Can HRT reduce high cholesterol?
I would not use hormone therapy for reducing cardiovascular risk. Really, if you have hyperlipidemia, you should work with your healthcare provider to be on an effective drug. And there's so many really effective and safe drugs for high cholesterol. So that would not be an indication for hormone therapy.
What if you cannot take hormones as your menopause was caused by chemo against cancer? What you do is sudden menopause due to cancer or surgical removals of ovaries the same as, quote, natural menopause?
So there's no doubt about it that women who go through menopause because their ovaries are removed or because they receive chemotherapy tend to have a much worse menopause. There's something about the acute withdrawal of estrogen. Those brain neurons just really fire. And so those women are usually much more symptomatic. And of course, it's also happening at exactly the time when they have just no gas in the tank. They're going through chemotherapy. They've just had surgery. This is an incredibly hard life event. So before this new drug, fezolinetant, the one that works in the brain, we were using SSRIs, SNRIs, the antidepressants, one of which is FDA approved for that indication, and they do work. Do they work as well as hormone therapy? No. Do they have their own risks and side effects? Yes, but they certainly help. Then there's some other off-label drugs that we use for hot flashes. I don't know if anyone, Neurontin or gabapentin, double-blind trials show that's more effective, not FDA approved. So there are definitely things that help. And the good news is even women with breast cancer can use low-dose vaginal estrogens. They should speak to their oncologist, but I know all of the oncologists I work with, if the lubricants and moisturizers and other things haven't done the trick and it's really affecting a woman's quality of life, speak to your oncologist. You can still be a candidate for low-dose vaginal estrogen therapy.
What's the data on the risk of hormones in terms of duration? Are there risks of using a patch plus a contraceptive insert, Mirena?
So lots of questions there. So in terms of the risks of hormone therapy, clearly duration of use does increase the risk. So in the Women's Health Index study, the women and advancing age. So most of the events that drove the front page article were in women over 60. Some women over 70, and that was really most of the bad cardiovascular events and strokes that got us on the front page. So clearly, advancing age and duration of use are relative contraindications to menopausal hormone therapy. With the duration of use is when we start to see more increase in that breast cancer risk. And again, in the beginning, less than 5 years of use, we actually don't see any significant increased risk. But after 5 years, it's that slight increased risk. And then someone asked about, there is a progestogen IUD that can be used instead of using like an oral progestin to counteract the effects on the lining of the uterus. Off-label, but a terrific way to manage that. Very easy. Don't have to take a progestogen. Works really well.
Do you think HRT is a good idea for women under age 65 to help prevent cognitive decline and unpleasant symptoms of menopause?
So I really think the principal indication for menopausal hormone therapy is bothersome hot flashes. And I bet that woman is, usually they come in and say, I'm really worried about my memory. I'm like, you're having hot flashes? They're like, yeah, I'm up twice a night, and the sheets are soaked when I wake up. So they really do tend to go together. If someone's only concern is cognitive changes and they are not having sleep disruption and vasomotor symptoms, no, would definitely not recommend menopausal hormone therapy for that. But if they're having cognitive changes and they're not sleeping well and they're waking up hot, absolutely. Again, not for the treatment of the cognitive stuff, but it should get better when they're sleeping better and we're treating the really bothersome symptoms.
Now, you're concerned about marketing to women. We've said that. But there are some products like cooling sheets. Okay, all right. I'm looking at your face.
Yeah, so
Okay.
what I would say is there are definitely good data that staying cool helps.
Okay.
So I think those things are incredibly safe. So on the other hand, you can buy an expensive thing on Amazon. You can get some frozen peas and keep them in the freezer during the day and put them under the pillow at night. So, yes, some of these cooling mattresses are like thousands of dollars. So, but on the other hand,
what about sheets? You can have sheets and not mattresses.
Sure.
Okay.
I certainly tell women, get rid of that. You can't imagine how many women come in, they're not sleeping through the night with vasomotor symptoms, they're hot. I'm like, do you have a down comforter? I love my down comforter. I'm like, you gotta get rid of the down comforter. I can't.
Yeah.
So, just simple, inexpensive things can make a really big difference.
Okay.
Light layered clothing, cotton, cotton bedclothes, things like that can really make a
Okay, so I've read that an increase in certain plants, like the chickpeas and the this and the that and whatever, is that? Yeah.
The great news is they will reduce your hot flashes 30%.
Okay.
Is that better than a placebo chickpea? No. But that doesn't
Okay.
mean it. I actually share this with my patients.
Okay.
But it works. And as long as I've shared with you the evidence, I want to be evidence-based, I think it's very reasonable to go out and buy the chickpeas because they are probably safer and less expensive than some of the things I might prescribe. And if you just need that 30% decline in hot flashes, as long as I've told you that may not be better than a sugar pill, if it works for you, it's likely safer. So the great news about placebos is they can still work even when we kind of know they're a placebo. So I think, especially if it's something pretty safe, acupuncture, it can be expensive, but as long as it's sterile disposable needles and a certified acupuncturist, if that gets you that 30% decrease in hot flashes and that's all you need, it's not better than shallow needling. On the other hand, that may be all you need as long as we're evidence-based and share that with our patients. I think there are a lot of things that can help.
Now, you just mentioned down comforters in terms of, aggravating a hot flash. Are there other triggers that people should be aware of in general?
You know what? I encourage women to really think about their own triggers. Every woman's different. A lot of women, hot drinks instead of cold drinks. Alcohol is a classic. And I had one patient who said, I am just not giving up my red wine with dinner. I know that's going to bring on my hot flashes, but it's worth it. So you just have to choose your triggers and make your decisions.
So let me go back to one of the stats, which always stands out for me personally. African American women, longer duration of these horrible symptoms. Please explain why, and is there anything?
Yeah. So, I'm so glad you brought that up, Callie. There are a lot of data now that Black women have more severe hot flashes, they last longer, and they are less likely to get hormone therapy and treatment. Do we know why? The biology is probably different genetics, but there are also social determinants of health. Smokers have more hot flashes. Where are we advertising and selling cigarettes? Right?
Yes.
A lot of communities of color. People who exercise might have a lower BMI. They might be able to manage their hot flashes better. Where are people having to work 2 jobs and not have that time for the leisure, the leisure walking? Maybe they don't have a safe place to walk. Maybe they don't have a nice park in their neighborhood. So I think it's a really complicated issue, and I'm glad you brought it up. But women of color are not getting the attention they deserve, and they're pretty symptomatic.
Okay, so of all the treatments that we've discussed, would either one, either the non-hormonal or the hormonal, work better for women, African American women with longer symptoms? I know it's individual, but
yeah,
I'm
I would
just
say it's
asking.
individual. I mean,
Yeah.
I think it would be shared decision making. And if the
Yeah.
woman really preferred not to be on hormone therapy, she should start with non-hormonals. If she's healthy and under 60 and has terrible hot flashes, she may choose to go straight to hormone therapy. But I think there have been no data that the response to treatment varies by race or ethnicity. It's more
Okay.
that you're less likely to be treated and have more symptoms.
Though I had heard that in Japan, for example, there's maybe a lower percentage of hot flashes because of the soy in the diet being predominant.
I mean, the multicultural studies of hot flashes are fascinating. For a while, we thought Asian women were having few hot flashes, and then someone said, I think it's because their culture is they're not supposed to complain as much.
Oh,
It's
gotcha.
hard to know.
Yeah.
And also, there's some really interesting studies that uh, again, I hate to speak for Asian cultures because I don't know these data well, and these are big generalizations, but they look at aging as much more of a positive, right? You're kind of welcomed into your family as a family leader, and that doesn't really happen here, right? And so how a society views aging may actually impact the bothersomeness of your hot flashes, right?
Okay, the topic of hormone therapy being covered by health insurance, is it?
This is, I brought up a little bit of my concerns with kind of FDA and government approach to menopause, but we really need some change. So I have had women who've had their hormones covered without any trouble at all until they hit 65. And then all of a sudden, it's on this list of dangerous drugs, and you're writing letters, and she has terrible hot flashes, and she can't sleep without it. And now it becomes really expensive. So we are not doing a good job about covering it for everyone. Typically people with pretty good health insurance are getting the coverage they need. There's a lot of generic, so that's terrific. For almost every product that I prescribe, there's a generic, and that's really brought down the cost, made it much more affordable.
For you, with everything that you've presented, is there one huge myth that is undermining a lot of our understanding of how menopause works, or even stopping our getting the information out and talking about it?
That's a great question. You know what I think it is? It's that I like the idea to think about menopause. This is normal aging, right? And we should embrace it. But the bothersome symptoms are not normal. They happen to a lot of women, but they can be treated. And so I think the myth is that somehow, well, this is just midlife and I just have to suffer. And that's a bad myth out there. And then, I think we have, as a society, a really interesting view of pain for women, whether it's childbirth or menstrual cramps, or when we're doing procedures, that somehow it's part of being a woman, and that's not true at all. We should not accept pain for anyone. And so these are painful symptoms and they should be treated. Women shouldn't just say, well, I've got to suffer because this is part of being a midlife woman.
Okay. Because part of being a midlife woman is I can't remember when I'm supposed to bring this to a close. And I have the clock, James, but I have to look at my cheat sheet. So, James, tell me if I'm going over, because I can keep talking, because I have many more things to do. I don't hear from James. I'll wait for him to tell me if I'm running over my time. I want to squeeze in as many people as I can. Talk a bit more about women without a uterus, hysterectomy, with or without ovaries. Can they still experience menopausal symptoms, brain fog, sleeplessness, mood changes, et cetera?
Great question. So first of all, removal of the uterus makes giving you hormones much easier, because women without a uterus, they just take one hormone, the estrogen, and that's the one that treats hot flashes. They don't need to take the progestogen because there's no uterus to protect. So actually, it is easier to find a product they like and treat the hot flashes. And on the other hand, I think the data I quickly showed from Women's Health Initiative, women on estrogen alone appear to have a much better risk-benefit profile for hormone therapy. So women without a uterus, if they're symptomatic with hot flashes, are really good candidates for estrogen therapy.
Okay.
If you've had your ovaries removed, as we discussed before, of course you're a candidate if you're symptomatic. And often women who undergo surgical menopause tend to be even more symptomatic, especially acutely, right after surgery.
Okay. You didn't mention weight gain as a symptom consequence of menopause. Can you comment on that?
Oh, I'm glad someone brought that up. So weight gain is really universal as women age. So when we really try to
Did
tease
you hear
out,
that? I didn't want to go over that. Okay, go
when
ahead.
we try to tease out, is it menopause or is it aging? It is probably aging. And women don't like to hear this when they come to the office, but menopausal hormone therapy will not increase your weight, but it also will not get rid of the 10 or 15 pounds you just gained.
Yeah.
So we think that with aging and menopause is related, there's just a change in metabolism. And I had a patient say it best. You have to burn more calories and take in fewer calories. And that is the only way to do it. So, there's so many other health benefits for exercise. This is a really great time to keep exercising. And then I remind women that exercise is incredibly important for health and weight maintenance, but you don't lose weight necessarily by exercising. Unfortunately, you've got to cut calories. It's the only way to do it.
Well, we didn't want to talk to you.
I know. There's like no magic. And then when people come in and say, well, what about this diet or that diet? They all work if you can find the one that you can stick to. So, whether it's all this or all that, just if it's one that works for you. A lot of my patients are really liking intermittent fasting. They're just giving up breakfast. And, there again, we talk about the influence of media and things on our healthcare. I grew up with breakfast is the most important meal of the day. And guess who funded that?
Yeah.
The cereal, Kellogg
Right.
or something. And, I think there are actually some health data that, skipping breakfast, that's a few hundred calories. You add that up over a week. So whatever it is so it's universal, it will not go away, and it will not get better. So you kind of have to tackle that one head on.
There's a couple men questions here. So is there a man equivalent of menopause? Yes, of course.
I don't really study men, but clearly aging has a lot of impact on men as well.
Yeah.
They can have osteoporosis, they can lose bone. They have a lot of the same changes that women experience in the workplace. We have a youth culture. I was really shocked. A friend who's a plastic surgeon said, 80% of my patients are men in business. They're coming for plastic surgery because they're supposed to look younger. So I think the things that worry us, I think some men will experience them too.
And these are two I can combine. What is the role that your husband, life partner, can play to support women going through menopause? And how can we desensitize men around this conversation?
Yeah, first of all, partners aren't always men, but I think partners are incredibly supportive. They may not be at the same life stage, but clearly having supportive partners, supportive friends, supportive families makes a really big difference. But I think we do need to be educating everyone because, yes, if people's partners are educated, they will be, really more accepting of the changes and symptoms and hopefully may even be proactive. I've had some women come to see me for their vaginal dryness and they're like, my partner said there were treatments for this. I'm like, I'm so glad you came. There were treatments for this. So I think partners can be really helpful for improving our health in lots of ways.
All right, your biggest takeaway. If we walk out of here and we don't remember anything else, what's the number one thing?
I think the number one thing is keep the conversation going. Talk about it, think about it, make sure you're getting the care you need. And that this can be a really terrific time of life, but you've got to get the treatment you deserve and treat the symptoms that are bothering you.
Well, I like that, and I like an inspirational comment. So here's one from Michelle Obama. The changes, the highs and the lows, and the hormonal shifts, there is power in that.
I love it. That's a wonderful quote. I've got to add that.
We so appreciate your sharing with us. This is fantastic. I hope we can spread this every which way to many other people. And as we conclude, I'm going to invite the board chair for the Boston Club, Lisa Pryor, to the stage.
Terrific. Lisa, and just before you, Lisa, I just also want to thank you, Callie, for the incredible education you're doing in health for people.
Thank you.
Ms. Callie Crossley, Dr. Jan Shifren, you are both national treasures. Callie, for the conversations you bring us into and illuminating the stage, and Dr. Shifren for being the unicorn who goes into the pioneering research. Can we just hear the most wonderful, heartfelt? I like that. Let's whistle. So, should the workforce and workplace change, or should treatment change? I say, why not both? And Tim, you opened and welcomed us to this wonderful museum that is such part of so many of our families in our community here, and you opened with the statement that science sheds light, that it brings truth to things and that are not always as they seem. And certainly we've heard some debunking of some very important myths this evening. And Insu, the Center for Life Science, you invited us to have conversation. You've helped us bring this conversation out of the shadows, and we thank you so much for that. Leadership can be lonely. Being a woman leader can be even lonelier. And Callie, when you said we internalize the stigma, we keep it in the shadows. We don't have the conversations, we tough it out. I'd like to share with you a quick story about a conversation. It was probably the first I've had with friends about menopause, and it was actually very recently, getting ready for today's conversation. I was at a kitchen table. 3 of us women were cisgender. We identified with the sex we were assigned at birth, and one of our friends was a trans woman. And I was saying, we want to be inclusive, and how do trans women fit into this? And our trans woman friend said, well, honey, let me show you my patch. And she showed us her patch. And then another cisgender friend said, well, let me show you mine. So then I was lifted, and I'm not going to do it here, to share mine as well. And another cisgender friend said, what patch? What's a patch? Should I have a patch? And it was the best conversation. It was so freeing. So what can we as women leaders do? Let's help destigmatize. Show your patch, talk about it, make it safe. And for our male colleagues as well to understand this is health equity. This is part of our journey. And speaking of health equity, let's not forget, let's always remember the differences across race when it comes to access. And if it's challenging for those of us who are not women of color, how can we be supportive of those who are women of color and bring these issues to light and advance them in the workplace? So a couple of things. I will always remember to learn where my car is. I have always loved candy, but now I'm not so sure about those neurons. That was a sort of mind-blowing sort of data point. And there's so many other takeaways, and we're so thankful to the Museum of Science for live streaming this, because now the link will be available, and those who could not join us this evening will have access and will be able to share this beyond Boston, beyond Massachusetts, and we would welcome you to share this with women and men and all people who might benefit from the information. So we are the Boston Club. We are New England's largest network of professional women. Our mission is advancing all women to tables that matter in corporate and community life. We're distinctive because we see leadership as a lifelong journey, as Ms. Crossley and Dr. Shifren have shared with us and illuminated tonight. We believe that when we bring together, as we have this evening, with our wonderful sponsors, with all of you, with our wonderful conversation here, that when we bring this together, we are a force for change in issues of diverse women's leadership, not only for healthy organizations, but also for a just society. And I am so proud and thrilled that we are living this mission and vision this evening. We thank our male allies for being here and for being, can we have a big round of applause? And for the questions that came from our male allies around that. We thank you, Museum of Science. We thank the Center for Life Sciences. We thank our corporate sponsor, Servier Pharmaceuticals, that has been sponsoring our Women's Health series. We thank McKinsey for the fabulous Megan Greenfield. Go find that study. We will be publishing it and amplifying it through our social media channels. And of course, the most heartfelt thanks to each of you for being here. We hope this has been a groundbreaking conversation, and we are very proud, and we thank our Executive Director, Barbara Hayes, and Veronica Accardo, who have done so much behind the scenes, along with James and Riley here, and so many others at the Museum of Science to make this possible. But it's not possible without each of you. So thank you, our heartfelt thanks for being here, and let's go forward and let's make some change. Right. Please feel free to come on down and chat a little
Callie, that
bit
was
for
so
a little
much
while
fun.
longer.
Oh, good.
Thank
Well,
you so much.
I'm really serious. That was the best presentation.